So you've learned what a frontal orbital advancement is and what goes on from that standpoint. And what I'm going to talk about now is LeFort 3 monobloc. Now, in a way, they're intimately involved with each other. But we have to really be sure that we're talking about the same thing again. Classically, if you have a single suture synostosis that's non-syndromic, rarely will you ever need a LeFort 3 or a monobloc. However, if you do have a syndromic problem like Apert's or Cruzon's, then most likely you will need both a frontal orbital advancement and then either maybe a LeFort 3 or a monobloc. So we're about to go where that is. You may even need them for people that have other things like clefts and so on and so forth. Dr. Urata does a LeFort 3 for midfacial hypoplasia. I do a high wing LeFort because, as I'll show you, LeFort 3s and monoblocs, really their main focus is really orbital volume and zygomatic projection. Because no matter what you do afterwards, your teeth are going to be taken care of by a LeFort 1. So classically, the treatment protocol for a syndromic child, Apert's, Cruzon, Say3-Schotzen syndrome, Pfeiffer's, would be at a young age, and Dr. Singh talked about what that age is. We're tending to do it later. She talked about posterior distraction. You might have some posterior distraction in a non-syndromic, but most of the time you're talking about posterior distraction in a syndromic. That's what you're doing. Rarely are we doing it in a non-syndromic. You might, for different reasons, but mostly not. So the first operation would be done in a frontal orbital advancement. In the old days, they used to do those young. We do them later and later. One, because of posterior distraction, but even before, there was a very high relapse rate of the frontal orbital bars coming back in kids that were syndromic. So when they used to do them at 3 or 6 months because they thought they needed to do it, they were doing it again at 18 months to 2 years. If that's the case, my feeling was, why do it in the first place? The thought was maybe because they have increased intracranial pressure and therefore you would relieve it. But as we were watching them, a lot of these kids didn't. Aperts have used fontanelles. Rarely do they have pressure in the early periods that you do, and you can watch it. And now with posterior distraction, you're giving them an awful lot of room, so that's not as important. So we went later because of 2 reasons. One is they were relapsing. 2, and I think we found this even now with regular non-syndromic synostosis, is there's much more structural integrity to the bone itself. Your plate can be as rigid as it needs to be, but if the bone is actually malleable, it's not really going to hold the plate all that well. So you're going to do a frontal orbital advancement. If that maintains its projection, then as these kids grow, remember that you are treating a symptom in a syndromic patient, you're not curing them. You're treating a symptom of their face. You're just treating those bones. So whatever problem they had, that genetic problem they had with a hypoplasia of growth, it's still there. There are some people early on, because they do have, some of these kids had exorbitism, they had midfacial hypoplasia at babies. So early on, there were people that were doing them, like Daniel Marshak and so on, would actually do it all at once, a frontal orbital advancement and a monobloc. So it was, instead of a frontal orbital advancement, just get a monobloc all the way out. That affair had a very high mortality rate. Got very dangerous in babies, so we don't do it in babies anymore. One of the greatest presentations I ever said was by Daniel Marshak in France, in Saint-Tropez. He gave an amazing talk. When you are experienced enough to talk about your complications, those are seminal talks that you always bring with you. He showed a kid that he did a monobloc on as a baby, and he thought it went well. Then he was called to the recovery room. The child was dead. They went to the morgue, and what it looked like is the pterygomaxillary disimpaction, the curved osteotome, went right into the cranial base, right into the brain, and that's what killed the baby. So they're very, very dangerous. Not many of us do that anymore. I don't do any babies that are there. I see that as a contraindication doing that. But the bottom line is, if you're not, then we're back to this paradigm. Frontal orbital advancement, then usually my timing is, depending on whether or not you have increased intracranial pressure, how bad the exorbitism is, and how bad the airway is, right? Because those are the 3 things that you're going to address with this that I'll get to in a second. At about, for me, anywhere from 7 to 8 years old is when I think about doing either a subcranial LeFort 3 or a monobloc. And when they get to maturity and they've had their orthodontia, you then follow up with a LeFort 3. So we're going to talk about, first of all, LeFort 3s, how you can do them, and whether or not you can do them, do you have to go intracranial or extracranial from that standpoint. So the reason, for instance, after the frontal orbital advancement, you do a LeFort 3 when they're 7 is because your frontal orbital advancement maintained its projection and it really looks aesthetically. So if it really looks good aesthetically, you should be able to look at that patient clinically and see where the LeFort 3 is. You should be able to tell your attending, yeah, you cut right here and you go to here, this is what needs to come out. Because that's what you did with the frontal orbital advancement. However, if the patient has significant exorbitism still and a recessed supraorbital bar, then a monobloc addresses the ability to get that out. Both a LeFort 3 and a monobloc addresses the other two main things, right, which is airway, because it actually moves that midface that's out, as well as your cheekbones and getting that area out, and the exorbitism. The exorbitism is sort of dealt with because you get increased orbital volume by moving through. So if you do a really good frontal orbital advancement, and they're 6, 7, or 8 years old, and you want to actually now just bring their midface out, you want to do a LeFort 3. Now the question is, do you have to get your neurosurgeon involved with that? There are some people that will always get their neurosurgeon involved with that, or at least to do a craniotomy, I should say. I pretty much have my neurosurgeons involved, but I don't always have them do it intracranially. The reason you do it, and I will show this a little bit, is because of one cut, really more than anything else. That's this cut right here. Because you have to cut above the cribriform plate in that area and be able to get that forward. So why would you ever do that extracranially? Well, if you could avoid a craniotomy, wouldn't that be wonderful? But if you're not sure and you actually bring that saw across and cut across the cranial base, that could kill the patient, cause all sorts of different problems to be able to do it. So often you'll open up and bring that area out. So what I look for is, where is the level of the cranial base? You'll love a coronal incision to be able to look at that, if this is out where that is. If it looks pretty good and it doesn't have a low-lying cranial base, I'll often get a stealth CT scan, and I'll work with the neurosurgeon, set them up in pins, and I'll actually make that cut extracranially, and then I don't need the neurosurgery in anymore. We do the rest of it that's there. If you have any doubt at all, it's better to be safe. Talk with your neurosurgeon. If they need to open up, that's fine. With a monobloc, you're always going to have to open up, but by definition, right, you have to move the supraorbital bar. So here we have a situation in which we're talking about where these, let me go back here. See, what you're looking at in over here is where, in the CT scans, you're actually going to sort of make these cuts to see where the optic nerves are and see where the cranial base is when you're sort of moving forward. Sometimes you have a wide and flattened cranial base. You really want to use your coronals to see where it is, but you sort of want to come across here without doing too much damage. So this is the LeFort 3 that we're talking about over here to be able to get that done. If your frontal orbital advancement's already done, you're fine up in here, and you just need to make this cut here. You need to come along in here, up and through here, and around the other side. So those are your cuts, pretty much, at the orbit. Then you've got to cut your zygoma. Then you have to actually cut your pterygoids to release it. And then lastly, you're going to have to cut the perpendicular plate of the ethmoid. At that point, you're going to have a craniofacial disjunction, just like a LeFort 3. You'll be able to get forward to see where it is. So it's this cut that we're talking about here if your frontal orbital advancement looks okay. This to me is even a little bit high. In the old days, there used to be an anatomical point where you would look at. It was the, where the anterior ethmoidals would come in, and you'd see the foramina in here. Used to feel, and in general it's probably true, that if you actually stay below the anterior ethmoidal arteries that are there, you're probably safe. These days probably is often not good enough, and it's wonderful to get a CT scan, especially with coronal, so you can see where that is. If they have low-lying cranial bases, and sometimes they do because they're hyperteloric, then you probably don't want to ding it by going in through here, so you want to see where you are there. That's a decision you have to make. If you're a young craniosurgeon that's out there, right, first do no harm. Do what's there. If you have a young neurosurgeon, you're going to come up together. You have an older neurosurgeon, listen to them. They're very brilliant people, and they're going to help you to sort of do where things are. I've been with one of my neurosurgeons for 23 years. At this point, I have a joint appointment, and her osteotomies and her craniotomies get smaller and smaller. She just opens it up and goes, you know what to do and call me if there's a problem. And that's what we do. But don't count on that in the beginning, and don't put yourself in a position where you're uncomfortable. These are big cases. Monoblocs are probably, I think, the biggest case that we will do going forward, getting there it is. So you want to see where this part is. So again, this is the cut that we're talking about. Now I usually do the reciprocating saw over here. This is a little bit of an oscillating saw that they have in that area. If the brain is open, then you have the craniotomy is open, you can have your malleables down there. You can come right across there and make sure that you're below that cribriform plate, right? If you're doing a subcranial LeFort 3. Right, to see where that is. You want to make sure you're below that. You're into the nose, right, but you're not up into the brain. You're not going to get a leak. You're not going to get anosmia. You're not going to hit any of those areas that are there. You're going to go right where that is to see where it is. If you're unsure, or if it's abnormal, or if there's a lot of adhesions in there and you're not sure, do the craniotomy, work with them to be able to go forward to get that part done. So here we can see again to where these things are here. These are these cuts that we're talking about. that are in through here, back in through here, around there, at the zygoma, and it's here. Now the problem with this, of course, is an AO thing here, not much of an advancement over here, and I'll show you my pictures in a little bit that are there, but this is more of a trauma LeFort 3, that's why. I'm going to show you the ones that we have that are a little bit there. This would be a traumatic LeFort 3, and that's why there's no advancement right here. There's just plates and screws that are there. But those are the areas you're going to be worrying about, and these are the areas you're going to be in here. There's a last thing too, whether we do monoblocks and LeFort 3s these days, something has really changed over the course of the last 5 to 8 to 10 years. And that is, most of my LeFort 3s and monoblocks have gone to distraction. Not all of them. And there are sometimes why they can't. And there are technical differences between doing the two that I'll talk about a little bit. But if you do a distraction monobloc, or a LeFort 3, all you have to do is make the osteotomies, make it loose. Then what I do is I re-register it back to where it was. What I like to do when it's there, and we'll talk about it, is after you've done that, even do these with high wing LeForts, after I've loosened everything, it's got to be really loose, I'll make little drill holes above and below one of the osteotomies and put a 6-0 monocle in there. It's small enough to re-register it so you don't get length and it's not in the wrong place. You sit there for your 5 or 7 days or whatever it is while you're waiting for your distraction regenerate to sort of form. And then when you start distracting, 6-0 is not going to hold it there. But a lot of times these things will, if they're not loose enough, you won't distract. If they're too loose, you can get a long face and get in the wrong area. If it turns out you're going to do it in a non-distraction way, then the difference is your osteotomies have to be in places that are going to allow plates and screws to be able to be on both sides, and you're going to have to put bone grafts in there. Now, you may always say, well, it's just easier to distract. You're done with the case, and then you put your halo on, right? Or do it in some way. But there are some patients that live really far away. They don't really have the patient or the family IQ to be able to deal with it. They're not going to be able to come back and forth. And if they won't, then if you're a hammer, the whole world is a nail. You can't just do the same thing. You have to be able to deal with what it is. So anyways, that's where we're going with that. Oops, I want to keep going backwards. This is more from what I do here. This is from one of the chapters that I wrote that's over here too. And you can see this is where we are. This is going to include this. This is a LeFort 3 that we have in the same way over here. This is one without distraction. It's sort of gone over here. You have to make sure that you're going to have on the zygoma, you're going to have to make sure that you have enough room on either side to put a plate. If this is a distraction, you don't have to be worried about that. But you do have to be worried about the bones being opposed. If those bones are nowhere near each other, they're not going to form a regenerate, and you're not going to get new bone formation. Now, the majority of bone formation, whether it be a monobloc, a LeFort 3, a LeFort 2, or a LeFort 1, happens at the pterygomaxillary disjunction area. That's where most of that bone forms. But you can get bone to form here. It's just a lot of times people are not as fastidious about getting it to the right place to where that part is. So, same cuts right along in here. Same cut, you can see the curved osteotome in here. But the difference in here is we have a bone graft in here and here. So what's that? That's a bipartition. So once you have that out, a bipartition can be done as a LeFort 3 portion or as a monobloc portion. And the way that the bipartition works is essentially what you get is, if you think about this being your apex here, if you take a V out over here and you split your palate in over here, then as you bring this area over here, depending on where that is, this will actually come out there. So many of these patients, we already know, have transverse palatal width discrepancies that are narrow palates. So you're getting the upside of the palate being expanded at the same time you're getting this part here. But if you're using it to deal with hypertelorism, which is the bug reason that you have it here, if you do it in a LeFort 3, your triangle, the upper part of your triangle gets smaller and smaller. If you do it with part of a monobloc, you're going to get a much bigger move than you would have the other way. So the amount of hypertelorism you can get with a bipartition is not as much as you might be able to get with a box. Box procedure, however, is not something you would do at the same time as a lot of instability to bring it in there. But part of the other things are there too is that you have to make an upper buccal sulcus incision. You have to be able to split the palate that's in here to be able to get that done too. One of the pearls about this also is, it was done a little bit different, so Dr. Posnick has published an awful lot about doing these monoblocks and putting a splint in here and getting it to a certain spot. I don't believe in that for the same reason I don't believe in VSP. Soft tissues are really, really important in some of the things that we do. I'm constantly looking at where those soft tissue recoil is and where that should be. If you know that, if you don't know where you're going to be, how can you do VSP when you don't even know where you're going to be as far as that goes? I'm trying to get this in the non-distraction case as far forward as possible, right? Because I'm not going to be able to do it again. The soft tissue envelope is going to dictate that a little bit. VSP can't tell me about the soft tissue at all, so it won't really be able to do it. If I put a splint in there, like doing model surgery, I've already predestined how far I'm going to bring it. I don't know how far that will be. The other part is the lower portion of a LeFort 3 is really not what's important. You're doing a LeFort 3 because of the orbit and the zygoma. Remember, you're doing a LeFort 1 down the road, so it's really not for occlusion. What I will do is I will put, at the beginning of the case, I'll take some methacrylate. While they're getting ready, I'll put it in there, and I just put some methacrylate to hit the high arch palate and put a little splint that's in there. It's not to restrict the splint as an occlusal splint, but it's something to give me something so when I take my turgomacular disimpaction and go down, I'm not ripping the upper portion of the palate. The other thing is, once we have that monobloc in there, it allows us to protect the palate and hold this as some stability. Because the stability we're going to get at the LeFort 3 or the monobloc is over here and over here. There's very little stability on here. That's a cantilever, so we're bringing it over here. So you can see afterwards, that's what this is. That's that intraoral splint here. It's not an occlusal splint. I'm not going for occlusion. When I'm looking at a LeFort 3 or a monobloc, I'm looking here, and I'm looking at the eyes to see where it is. If it's a monobloc, you're also looking at the frontal bar to see where that part of it is going forward. Oops, keep going backwards. So you can see, after those cuts were made, the wonderful thing about this, and again, you can see, this is an old-fashioned sort of LeFort 3 without distraction. One of the reasons that sometimes can be a very nice thing to do is you can do a facial bend too. I've cut this right down the middle. Now remember what I said? You're getting this forward, that's why you're looking here. And these are now moving apart, right in over there. And then I can put a splint in just sort of to hold it there. So you're increasing transverse width of the maxilla. You're getting hypertelorism taken. Many of these kids are dish-faced. So you're doing a move like this to get that mid portion out. Now, when you do distraction with a red device, the nice thing about it, the pull is from the middle. So that's sort of what's going to happen, is if a boat is going through the water, the lateral areas are going to be a little bit further back than the middle. But that's what you want to get a convex profile. So you want a convex profile in the front, and you want a convex profile in the back. You want to bring this far, so you increase orbital volume. So actually, these look better in that regard. And then, if it turns out that that's all you want to do at this level, you need to rigidly fix it. If it's not, you're not even doing this stuff. You're just putting those sutures in. You're letting your regenerate form. You're doing your latency period, and then you're getting started. But if not, you now have to plate this. And this is what I was talking about before. For this bipartition, which is now split, you take that bone out, you bring this together, you put a little drill hole in both of this. I like to put a wire in and you twist it. And as you do, that'll come forward, that'll come like this, and the bottom will go out like that. Then you advance it. Now, if you're doing it on the table, as opposed to a distraction, you bring it out like that and you bring it into the bend, and now what you have to do is you have to, again, look on the table. How's DSP going to do that? Because I do that on the table. You get behind those areas after the osteotomies, you get behind, I flip everything back, and then I push it out, and I figure out what looks right. And I also figure out what the recoil of the soft tissues are. And at that point, when it's set, you then have to set these plates. These plates can't be 1/0 little plate wire plates. They're going to have to be as strong as you can be without being too big that they're going to be palpable. Often these are 1.5s or 2/0s, depending on where these areas are. These are areas of structural integrity. I try to hide them in here. I have a little plate in here. You have a plate over here. Notice there's a bone graft in here. With distraction, you don't need a bone graft, right? And then you put those areas up in here. And in this case, it's a LeFort 3, so the monobloc area is where it is. So you just have to bring it up here to allow where that is, or maybe even a little bit further and then burring it to see where it is. What am I looking at when I'm there? I'm looking over the table. I have this flipped up. I'm looking at the convexity. I'm looking at the eyes. I'm making sure those eyes are back far enough. Besides looking at the eyes and seeing if they're back far enough, I'm looking at the cheekbones and making sure they're far enough. That may mean the teeth are going to come like this or like that, but what are you going to sacrifice? This is the last time we're coming back here and here. You got a LeFort 1, you can go over here. So the idea of coming into occlusion, I think, is wrong-headed. What you really want to do is get this exactly right, get it plated, figure out where you are from a north-south situation, plate it and get it where it is, and deal with your LeFort 1 down the road that you can get done. So now I want to show you some pretty important technical thing that you need to do too. Whoops, So this is a patient, well, I got to get there with the monobloc here. So this is a patient that needed a LeFort 3. She's a syndromic patient, never had a frontal orbital advancement, right? She just came in. Her main problems to me were not this. She was out. This looked like it was out far enough for her. But look at the midfacial hypoplasia. Look at the exorbitism that she got. She has downward slanting palpebral fissures. So this is now postoperatively. What I want you to show you is, again, no distraction here. This was in the old days, right? So look at the eyes. Now, the interesting thing about these eyes, too, that you're going to have to deal with also is these eyes have been like that for her maybe 9 years. So they're sort of like a woman that's been pregnant multiple times. After a while, that area gets lax, and it needs time to go back, right, to be where it is. Don't run too quickly to take care of any of the laxity in the skin. A lot of it will get better over time to see where it is. But look at the difference in the eyes where there are, where their canthuses are, where there's. Now, obviously, the lateral is really going to be a much bigger and nice thing to be able to show. But look at the eyes. Look at the areas that we're talking about in here. That's what you're shooting for. And if that's what you're shooting for, again, that's why I think VSP doesn't work for me. This is what I'm looking for. It's not pre-done. I don't know where those are going to be. In a LeFort 1, when you're dealing with occlusion, that's a different situation. You go to where the occlusion, you're going to lock into a very particular hard stop. Here, it's about the soft tissues sort of going forward. So, article first published by Ortiz Monasterio in 1978 talking about a monobloc. It's advancement of the orbits and the midface in one piece. There is some argument about who came up with the first thing that's there, but I think it is Dr. Monasterio that did, and other people used it. So the monobloc, or frontal facial advancement, pretty much, I've shown you, is now the LeFort 3-1 put together all at one. It is an amazing operation, but the biggest and the most dangerous one most craniofacial surgeons will do. Comes up with a lot of potential complications. Now remember what we talked about. This is in the old days. This is an old thing. I'm showing you this on purpose. These are wires. Remember what I told you about a bandeau? This is the old tongue and groove techniques, because that's the way they stabilize these things. Or in the old days, they'd have external fixators. We now have rigid fixation, so it makes a big difference. You can never really get that done. But the main thing is that you're going to make these areas increase orbital volume, move the cheeks out, move the forehead out to be where it is. Now, sometimes these are overstated because sometimes these supraorbital bars are not just symmetrically back in the exact right place, and you'll have to deal with that sort of going forward with there. The great thing about a monobloc is it addresses the major concerns for many patients with syndromic craniosynostosis, both functionally and aesthetic at the same time. But it's a bigger operation. Airway, number one. You look at these kids that have this midfacial hypoplasia. Sometimes erroneously, when they are born, they will be given a diagnosis of choanal atresia. The reason they're given that diagnosis is because once they're born, a pediatrician tries, or a neonatologist tries to pass an NG tube. If they can't pass the NG tube, they call it choanal atresia. That is not why it's happening. Their midface is so far back, they cannot negotiate the curve to get back down. So these kids don't have choanal atresia, they just have a very narrow airway that they have and they can't get by. That's why they have airway difficulties. Now, that's why many of those craniofacial surgeons were saying, why don't we just address this in infancy? But because of the high mortality, people got away from it. But their heart was in the right place, right? But the road to whatever is with good intentions, right? So you know, even though they wanted to do the right thing, it became a dangerous thing to be able to do. So airway, by bringing that forward, you now bring the choana away from the posterior pharyngeal wall, and the airway opens up. Just like we do with distraction for many of these other cases that we have, that airway opens up, and you can see it in sleep studies. They just get better. Second is globe exposure. The globe is exposed because the orbit is too small for a normal eye and the periorbita. That is what exorbitism is. A lot of nomenclature here problems, right? Proptosis means the eyes are out too far. Exophthalmos, I think, is really something a little bit more, to me, to Graves' disease. So I don't like to call it exorbitism is thought to be that you have a congenitally small orbit with a normal eye, and that's why they're sort of out there. So by increasing orbital volume, the globes will go back. Now, you can try to temporize that in a baby by either putting some lube in there and some saran wrap. That's really temporizing. You could do a lateral tarsorrhaphy. That's another way of temporizing. So there's lots of different things that you can do that you have to talk about doing if you can get there. But when they get older, if those are persistent, they can keep boop on there and so on, is when you bring this forward, you increase orbital volume and your globe exposure goes. The next one is ICP. You can't change ICP with a LeFort 3, right? It's below the cranial vault. But if you have a child with slit ventricles and a shunt or no shunt, actually most of the time we won't do it in a patient with a shunt, and I'll explain why. But if a patient has slit ventricles and they look like that the cranial volume is not big enough for the brain, doing a monobloc will give you increased cranial volume at the same time and relax and give this patient room in the brain. And then finally, aesthetic. It's a wonderfully aesthetic operation to get a patient better. So I want to show this because you don't really get to see many of these anymore. There's not a lot of patients that won't get these operations done because they are really problematic. This was a patient very early in my career whose mom and dad would not consent to the operation. So you went back and forth to court because they wanted to guarantee that if we did either a monobloc or even we did a frontal orbital advancement separated by a LeFort 3, we could guarantee that he wouldn't go blind, that he would be alive, and everything would be perfect. Well, you can't make any of those guarantees. So they decided not to do any of it. Well, now you get to watch what's going on here. So what did we say that it does? Exorbitism, right? So he's partially blind. His eyes are essentially herniating out of these areas that are there. So that's what we would have addressed when he was younger. Notice he's got a trach because because we talked about the airway, and he's got midfacial hypoplasia, and he certainly doesn't look like he's developmentally normal. But you can't make those guarantees. You can fight out in court and do whatever you need to do, but it's an ability to see that. So here are dangers if you don't do it. High ICP, globe exposure, and airway compromise, and you have to at least address them. The two major drawbacks are that due to the osteotomy at the skull base, there's retrofrontal dead space and potential contamination. When you make a cut, you're making this cut in front of the cribriform plate into the nose, and then you're bringing it forward. Now with distraction, you're leaving it where it is and you're forming a regenerate, and then you are stretching that. So theoretically, there is no dead space, and you're bringing everything along with you. It's not exactly like posterior distraction because there you're not even moving it forward and leaving where it is. To get your dissection in the front, you have to separate it from the dura to be able to get that done. But there is less dead space. In the old days, and when you do it there, immediately you have dead space. And then beyond the dead space, you have a free opening into the nose. And this is in the sterile compartment of the brain. So as you can imagine, the incidence of infection for a monobloc was high in comparison. Now there are things that I'll show you that we do about those things to be able to get that done, but that's one of the reasons that they're more risky, and one of the reasons why they think the distraction is a little less risky as they go there. Literature on that is tough because you need a bunch that are out. So let me explain that with, again, going back to a chapter. This is where we flip this area. The coronal flap is flipped closely. Remember we talked about, so the difference between the monobloc and the LeFort 3. The LeFort 3 making a cross over here. The monobloc, we leave this attached. You have to go intracranially, and now you make the cut in front of the cribriform plate. Now it all comes around, 2 donut holes. Getting that area out is going to move forward. So you're now looking down. This is where the cranial base is. This is where the area that is advanced. So there's dead space in there. You can deal with that dead space a couple of ways. One of the things that I do is, the first thing you do is you go down there, you find the nasal mucosa of the area where you cut, you try to find the edges of it, I over-sew it and throw it down. After that, I take a bone graft into that area and I put an interpositional bone graft in that area. After that, I'll either take pericranium and sew it down, or sometimes the neurosurgeons like to take a pericranial flap and put it in that area. The reason I don't like the pericranial flap is it's got a pedicle, if you truly believe it's a flap, and wherever they take that pedicle from ends up being a little bit of a thing that doesn't look all that great. But if you're really afraid of it and the neurosurgeon insists, that's what you do, and then you can go back at another time and deal with the pedicle of that area that won't look all that good. But it's really important to do a lot of fastidious work at that area to try to decrease the incidence of infection. And here now, you saw my pictures of what a LeFort 3 looked like, right? So this is now a monobloc. This is at a higher level because it includes the supraorbital rim, right? But now your bipartition can be higher. The higher it is, the wider your triangle can be, the more you can hear the hypertelorism and the more you can actually move things out in this way. So it's the same thing. That gets split. This is the area. This gets moved over. These get moved up. This is expanded, you're plating it here, you're putting a bone graft up in here, and your frontal orbital advancement comes in that area, but you did that work. Now, if you do look at these kids and you get a CT scan on them a year later, the brain will have filled in that area that's there. But it's the waiting during that time that's difficult to, during that time where the infection potentially will happen. Whereas a distraction is sort of taking a lot of it slowly and coming along with you as it goes forward. So again, 20 years ago, sort of a big paper that was written by Marshak and Renier, they talked about a 30% rate of infection, 15% mortality, right? All comers, infants, shunts, and older patients. So this reminds me, what are the contraindications to doing a monobloc? They're not complete contraindications. I won't really do it on a baby unless you have an amazing emergency to be able to do it. And even then, it won't really hold. You don't really have the distractors you need. There are some makeshift things where people will put a pin across, but there's no great baby distractor, red devices that you can really bring out. It's difficult. You can do an internal device, but the problem with doing internal devices in kids that are younger than 5, 6, or 7 is that the sutures, the facial sutures, are usually not strong enough. So as you distract them and bring them forward, they'll break. Even doing a 5-year-old non-distraction often will break. Dr. Kawamoto did a 5-year-old because we had to do it one time and it broke into 5 pieces. I remember called it a quintablock instead of a monobloc because it broke everywhere. And then what you have to do is go back and fix those. You have to put either plates or sutures in to be able to get that done. So infants, usually a relative contraindication. Shunts, contraindication. Why? Why? What is it that I just said that would make this have a higher likelihood of infection? Why is a shunt, even if it's back here, going to make it more difficult? The dead space, right? So we talked about the fact that we have dead space to begin with, and what will happen over time, I told you, a couple months later, if you take a CT scan, the brain will actually fill that area. But if the brain's decompressed with a shunt, now that's not going to happen anymore, right? So you're at a higher likelihood of getting an infection, and then they have a shunt, so it's very difficult. The last thing, doing it in adults, you can do it, but it's a problem too because they have frontal sinuses many times, and therefore that has a higher incidence of infection. So, you know, it's a powerful technique. 2 operations, by the way, are also risky. If you're not going to do it, then you're going to do a repeat frontal orbital advancement and then a LeFort 3. That's your other option, or leave them not looking good and not having a good operation. But if you want to give them, that's your other operation that you can do. That's not necessarily a good thing either. So you don't want to use it in shunted patients. You want to avoid full finus development, or I like to do it at 6 to 8, and you would want to address the cranial base osteotomy that we talked about. So again, that's the LeFort 3 that we talked about. This is the same one that you might move to that, or excuse me, that's a monobloc. These are the different cuts that we're talking about. You're making circles around this area. So how do you get that done? Well, first of all, you have to actually first do the dissection. You have to come down the deep temporal fascia, bring it down on the deep temporal fascia. You want to avoid dinging the frontal branch of the facial nerve, which comes up and perforates or writes just underneath the mid portion of where this is. So I was showing some of these before. You take on the deep temporal fascia, you come right down to here. You get to the medial side and the lateral side, and then I make the cut in the attachment between the deep temporal fascia as it's going under that area on the back part of the zygoma and get into the periosteum. If you get there, then you can make this cut over here. Laterally and superiorly, you can make all this. You make this intracranially. You come from above with a small osteotome in the lamina propria. You want to do that behind the medial canthus because you want to bring the canthus with you. You then come around in here. I can make the osteotome, I can come in from medial lateral over here. People that are uncomfortable doing that because you're just not there, and this bone can be a little tenacious and tough, you can do a transcon incision if you want, flip it down, and take your osteotome and make a really good incision and osteotomy in there. I make then an upper buccal sulcus incision. I take a Lindemann burr, I bring it into here so I can break it open a little bit, and I put a little osteotome in there, and I break down the midline of this suture to see where it is so I can get that part open there too. And I also do my pterygomaxillofacial impaction just like I do them for LeFort 1s and LeFort 3s from the inside. There are some people that are not as comfortable to do them from above. The other part is you want to get the stuff loose so you can move it. So just like I do with a pterygoid here, you can actually go with your row disimpaction forceps, but even after that, I like to put something behind the pterygoids here, either a Dingman elevator, or I'll use my obigazer and stretch it out. It's a feel thing to get it really stretchy so that you'll get where you want. That's important for both distraction as well as moving it. You can't even move it if you don't get it that far to be able to do it. If you get ridiculous and it pops out, that's a really bad thing, and you don't want that to happen. So you got to really sort of feel what you're doing here going forward. Again, those are the pictures they have. So how to make it successful. A full osteotomy, reposition your segments, even if you're doing distraction. Remember I talked about the 6-0 monocrol? A bipartition off the skull base from the Mohs, you can do it immediately. You want to take the bad shape, and you don't want to just take a shape that looks funny over here and just move it out over here. So that's the downside of a distraction monobloc a little bit. If they have a really funny face that's over here and you just bring it forward, you really have not helped them at all. So even if you want to, you could theoretically distract them. do a bipartition, get them sit in there, and get your splint to come in and come around that. Sometimes that's a little bit more difficult. And you have to make sure that you're stable at the time. You might want to put them in retaining elastics to get things out front, because most of your stability with these are up top and not in the bottom. Belt and suspenders, I like to use overcorrection and get things where I want them to be, even when I distract. You correct the eyes and the zygoma, not the teeth. You have to down fracture. I like a down fracture splint, but I don't like an occlusal splint. And you might have to do a transconjunctival incision to do what it is you need to do, right? But you deal with all three things at the same time. This was one of the first ones that I did. You see how old she is, right? So already I inherited this. And I'm sitting there, she needs a monobloc, but she's older. So we did do it. It's not a pretty nice result that's right over here for where she was before and after, but you're going to get much better off when they're older and get a better situation. Versus somebody that's got more of a cruise-on syndrome that needs it. He's got great soft tissue to begin with, and you can see really nice result there. You can get the convexity with somebody like that. Or somebody like this who's now an Apert syndrome, and you're going to see, this is probably one of the cases where you say this is such a transforming operation. To take a kid like this and one operation, make them look like that. It's a great operation, but it's tough and it's long. This is a patient too. Look at the eyes and see where it is. Remember what I was talking about? There's so much exorbitance in such a long period of time. That's where it is. But look at the convexity that you'll get. Look at the difference between the eyes. I mean, you'll get amazing results. This is like 18 operations. The guy comes to you and says, help me, and he's an adult. Lost bone, very difficult. So you have to say, do you really want to tackle this? And you have to figure out where it is. But you can make a huge difference, and that's why you really are thinking about it sometimes, from before and after, to see where somebody is like this. Or this girl too. Look at those eyes. Remember, it's about the eyes and the zygomas as you move forward. Look at the convexity and the difference that's there. It is transforming. It takes somebody that looks syndromic and somebody that just looks odd to somebody that looks so much more normal. These operations are about there to get that done. So again, distraction, the only difference is you're doing it now instead of there. We're using that, and I use it. I do it at 2 levels. There's lots of different ways to actually get that done. But again, these are transforming. Look at this girl before, see where she is, and we're doing now. You see we're supraorbitally, which is going to be a monobloc, because you see where these eyes are on both sides because that supraorbital advancement. Look at where her midface is to start with. This is where she's going when you distract her. You can see the differences that are there. And then you look at where she was, but it just doesn't even look like the same person. I mean, what's make you love this is what makes you love craniofacial surgery. It just does. I mean, you know, ears are pretty neat because you're taking them out of nowhere, but this is, look at the difference here. Look at the difference you're making in this person's life. But these are dangerous operations, but this is what you can do, and it's really exciting to get that part done. It's another girl here, mid-face that's out, distraction, and just really being able to get them out there. The distraction allows you to deal with the functional matrix. You are restrained a little bit, just like we are with just frontal orbital advancements, because you can't stretch that gaily out in the functional matrix. Here you can. See, look at the difference. I mean, it's just before and after, it's just really big differences here. So this is the last case I just want to show you real quick. This is a 2-year-old, right? So what are we going to do? He's a Kleebot shadle. In one operation, I was able to take him, I was really proud of myself, from an operation like that to this, right? But then watch what happens. Then my neurosurgeon puts a shunt in. They're like, oh, but the brain wins. You know, it's always important. She puts a shunt in and she goes from that, and then he goes back and he starts to fall away. Now, even when you treat him and get him out and he's in there, you still haven't treated this. But the problem was, at 2 years of age, his Pfeiffer syndrome, he started to have myotonic spasms, he had a shunt in, and he had slit ventricles and a tight head. So what are you going to do, right? So we wanted to deal with those when the shunt sort of contraindicated with the old-fashioned monobloc, but his eyes are popping out. They're thinking of doing either tarsorrhaphes, they're going to put a trach in. That's what they're talking about, trach, tarsorrhaphes in some way. And then remember, his head is too small for what's going on too. He's already got a shunt in and slit ventricles. He's got sleep apnea, so he's going to have a trach, right? What we wanted to do is expand the cranial vault, increase orbital volume, expand nasopharyngeal airway. A monobloc addresses all 3 things at once. And this is what we did. I showed you what those were like before, except we did it with internal distraction that I did here in the kid. And not only did I get to where he was, this looks pretty good, but I believe in overcorrection because we're not curing anything going forward. And you can see where those are and what a difference it sort of makes there. So it gives you an option. But these are really difficult cases. What are you going to do here? These bones are soft. It's very difficult. So anyways, I'm happy to take any questions that you have, and we can go over some of the stuff that's there.